Position of the ACL reconstruction is the main cause of the failure rates, such as from the loose impingement, improper tension of the graft. There is no clear evidence that the double bundle ACL reconstruction is superior to the single bundle technique because the double bundle technique did not clinically confirm biomechanical finding. The tension at the PL bundle in the knee extension could be so high, no significant difference in clinical outcome, and rarely performed currently. So today, my talk will mainly focus on how to perform the single bundle technique with a good position of the ACL graft and how to create a good clinical outcome. So recently, there's useful guideline proposed by Dr. Howell, the acronym ideal femoral tunnel position that based on the anatomical, histologic, isometric, and biomechanic and clinical data. I is isometric. The first is isometric. So from the study, non-isometric femoral tunnel placement can cause the recurrent anterior laxity from abnormal graft tension during the range of motion of the knee. So we have to achieve the isometric femoral tunnel placement to maintain the function throughout the flexion and extension to replicate the most isometric fiber within the native ACL. From the review literature by Dr. Sanwas, Giron, Simon, and Panchos, not all the fibers of the ACL are under tension during knee flexion and extension. And the center of the femoral footprint is less isometric than a tunnel in the more anterior region of the footprint. So from the literature above, so the most isometric region should represent by the light blue shade. That should locate eccentric position and specifically located proximal and anterior within the footprint. About the dialect, based on the historical finding from Dr. Iwahashi and Sasaki, the dialect fibers is dense and strong and is located within the footprint more anterior along the lateral intercondylar ridge and is play a crucial role as a key ligament bone link transmitting load. On the other hand, indirect fibers is less dense, weaker, and located more posterior, and character like a fat-like extension shape extend to posterior region. About the biomechanics study by Dr. Nawabi, the high fibers of the femoral footprint near the lateral intercondylar ridge carry more force compared to the fibers in the low, and the ACL fibers located in the high AM portion of the femoral footprint of the ACL are more isometric than fibers placed in the lower region of the femoral footprint. That you can see from the picture that the high AM is more isometric than other sides. So from above, the femoral position placement that represented by solid line should be positioned in the direct fibers eccentrically anterior along the lateral intercondylar ridge and should be in the footprint. And we have to avoid placing the tunnel in the centrum. About eccentrics and equidistant, based on the biomechanic consideration, that time zero stability of the knee restore the low tension flexion pattern in the ACL graft. From the study by Dr. Markov, the superior time zero of the knee stability we should be place the femoral tunnel placement more centrally in the footprint rather than outside the footprint, and should be located more anterior and proximal as compared with the tunnel in the more central or posterior region of the footprint. And from the study by Dr. Morgan and Ma's study group, We have to avoiding impingement because it's one of the critical for graft survival. There's two different types of impingement, most common loop and PCL impingement. And how to avoid this impingement? The femoral channel placement should be placed equidistantly from the bottom and the top of the knot. And a channel back wall should have a thickness of 1 millimeter to avoid impingement. So the favorable time zero stability and low tension flexion pattern should be represented by the orange shade. That this region should located equidistant from the top to the bottom of the knot, eccentric position, and specifically locate proximal and anterior in the anterior part of the footprint. A is anatomical consideration. That the non-anatomical placement of the femoral tunnel can be the cause of the failures of the ACL reconstruction, such as from the vertical graft placement, PCL impingement, recurrent rotational instability. So you can use the anatomical landmark to identify the anatomical footprint of the ACL reconstruction. First is the lateral intercondylar ridge. That defines the anterior highest region of the femoral footprint. And the ACL footprint fiber extend along this ridge, but not anterior to this bony ridge. And if you want to separate the ACL into two parts, you can use the bifurcated ridge to identify this area. So from that, from the above, the femoral footprints of the native ACL should be represented by the purple shades, and it's like an oblong in shape, extend from the lateral intercondylar ridge anteriorly to the articular cartilage posteriorly. And femoral tunnel should be in this footprint. About L is low tension and flexion. From clinical data consideration, the study from Dr. Lubowitz, the low tension flexion pattern of the native ACL should be achieved throughout a range of flexion and extension to replicate the tension flexion behavior of the native ACL. And from the review literature conducted by Dr. Simon and Sanwas, the change in the graft length and the tension of the ACL graft vary depending on the position of the femoral tunnel. The femoral tunnel that placed in the posterior region is high tension of the graft and high graft change more than in the centrum or in the eccentric area. From the literature above, the low tension flexion pattern of the native ACL should be represented by yellow shade and located in eccentric position anterior region of the footprint. So from of above, the acronym ideal femoral tunnel position should be represented by the black shade. That should locate more anterior in the posterior region and not outside the footprint. And about the tibial footprint, the variation of the shape of the tibial insertion site from the study of Dr. Fu, there's three common shapes: elliptical, triangular, and C-shape. The shape of the insertion site is one of the factors in determining individualized ACL reconstruction. They propose that the elliptical shape we can use a single bundle technique, and about the C shape we can using a double bundle technique. So from all of that, individualized anatomical ACL reconstruction for the femoral tunnel, we can follow the ideal femoral tunnel concept and the tibial tunnel. We can use the shape of the tibial insertion is one of the factors to choose the technique for ACL reconstruction. And future research and study should be focused on improving the reliability of the femoral tunnel technique, adhering to the principle of the ideal concept. Thank you for your attention.
Thank you, Dr. Suthee, for your excellent presentation.